Welcome all again. I would like to welcome all the 3,000 attendees who are still with us in the second day of the annual Saudi Hematology Congress. So we will start the next session, and we have Dr. Rami Komrokji, who is a hematologist and clinical investigator from the Moffitt Cancer Center. He has a special interest and several ongoing trials in myeloid malignancy, MDS, acute myeloid leukemia. Dr. Rami, he will talk about new therapeutics and new targets in myelodysplastic syndrome. Dr. Rami, the floor is yours.
Assalamu alaikum. Thank you for the kind introduction and for the kind invitation. So in the coming 25 minutes, hopefully I'll be able to cover some of the new advances and promises in myelodysplastic syndrome. Finally, we are following the heels of AML with new drugs and exciting clinical trials. Those are my conflict of interest. And as you know, myelodysplastic syndrome is a heterogeneous group of neoplastic stem cell diseases, presents with bone marrow failure, cytopenias, and the related complications, tendency to progress to AML. Not every patient progresses to AML. Around 30 to 40% will, but unfortunately around 50 to 60% of the patients will die from complications of the disease, namely related to cytopenias and its interaction with other comorbidities. Nowadays, we can demonstrate evidence of clonality either by cytogenetics or somatic gene mutations in almost 90% of the patients. And as it's well known, dysplasia still is the hallmark cytologic morphology of the disease. Upon establishing the diagnosis, we usually risk stratify the patients. And the most used staging system at this point is the revised IPSS, where we divide those patients into 5 categories based on the blast percentage, cytopenias, and the cytogenetic abnormalities. And we try at the end to divide the patients into 2 main categories: lower risk group, where our goal is going to be alleviating cytopenias, treating anemia, thrombocytopenia, etc., or a higher risk patients, where our goal will be trying to improve the survival and alter the natural history of the disease. We currently complement the results of the revised IPSS or the risk stratification by looking at the somatic gene mutations. This is work by Rafael Behar many years ago, looking at 5 gene mutations that any of them upstaged patients' risk group. And we complement that with the revised IPSS. I think it's what to remember importantly, obviously, TP53 is one of the worst mutations in myeloid diseases. The only favorable mutation in myelodysplastic syndrome is really SF3B1, which is a splicing mutation. So this is currently our treatment algorithm for patients with anemia for lower risk disease. In most of the lower risk cases, we are treating for anemia. Rarely 10% will need treatment for isolated thrombocytopenia, and neutropenia typically is not symptomatic, so I usually don't treat neutropenia alone. The presence of other cytopenias like thrombocytopenia or neutropenia could dictate your choice of therapy for anemia, but not often the indication. Most of MDS patients obviously present with anemia and eventually, become transfusion dependent. So erythroid-stimulating agents for anemia are still reasonable option, particularly in patients with low endogenous serum EPO. For patients with deletion 5q, lenalidomide is the standard treatment for those patients. Nowadays, for patients with MDS with ring sideroblast, Leuspaticep, which we will talk about in details, is approved option. For other patients that are non-del5q, that don't have ring sideroblast, if they are young, some institutions, if they have hypocellular bone marrow, we favor immunosuppressive therapy. This is a short course of treatment with durable trilineage responses. Finally, for the rest of the patients, if they are not young and don't have deletion 5q and don't have ring sideroblast, options could be still lenalidomide for the non-del5q, plus minus erythropoietin. We just published our study from the US intergroup looking at the combination len-EPO in that category, showing higher responses, or hypomethylating agents. And sometimes we pick hypomethylating agents in presence of concomitant thrombocytopenia or neutropenia. So we reserve the use of lenalidomide in the non-del5q for patients with pure anemia. So Leuspaticep is the first drug approved in a decade now, or more than a decade now, for MDS. and it's a neutralizing antibody that binds and neutralizes TGF-beta ligands in the serum before binding the receptor. And it turns out that TGF-beta ligands or TGF-beta pathway is important in MDS, being overactivated, contributing to the myelosuppression. And many of the TGF-beta ligands actually work as negative regulators of the terminal erythroid differentiation, blocking the last step in erythroid differentiation. So what Leuspaticep does, it binds those ligands in the serum, neutralizing them, and leading to release of the terminal erythroid differentiation block. So we use the term erythroid maturating agent. We originally did studies with Sotatercept, which is a similar compound that demonstrated the first activity in MDS. Then our colleagues in Germany did the initial studies with Leuspaticep. With both Leuspaticep and Sotatercept, we observed higher responses in patients with ring sideroblasts, and that led to the Medalist study. I'm not able to advance the slides. So the Medalist study that led to the approval of the drug.
Okay, can we move this next slide, please? Technical team.
So the Medalist study randomized patients with lower risk MDS, no blast, ring sideroblast, transfusion dependent, to either Leuspaticep or placebo, and the primary endpoint was transfusion independence.
Sorry, Dr. Rami, we're waiting for the technical team.
I think perfect. Thank you. So this is the design of the Medalist study, as I mentioned, between Leuspaticep, which is an injection every 3 weeks, and placebo. The baseline characteristics are shown here. Almost half of the patients were heavily transfusion dependent. Obviously, as expected, 90% of the patients will harbor the SF3B1 mutation, and most of those patients had prior ESA use. The small minority that did not have erythroid-stimulating agents had high endogenous serum EPO, predicting low chance of response. And this is the bottom line: the transfusion independency at 8 weeks, and at the 16 weeks. Obviously, Leuspaticep had around 30% transfusion independency in the study compared to the placebo, meeting the primary endpoint. And when you look at the details and the erythroid responses, it really turns out that those patients that are not heavily transfusion dependent, so introducing the treatment early on, have the highest yield or benefit from the treatment. So the mean hemoglobin increase in those patients that were less than 4 units blood transfusion dependent approached almost 70% with using Leuspaticep. The major side effects were fatigue, some edema, some GI toxicity, namely or mostly during the first 2 cycles of treatment, and that subsequently subsides. We usually start with a 1 milligram per kg dosing. After 2 doses, escalate to 1.33, and after 2 doses to 1.75. And if no response is seen, then we stop the treatment. If patients are responding, obviously we continue. In our experience, if patients are heavily transfusion dependent, they need higher dosing of the Leuspaticep, and it's being explored in patients with upfront MDS compared to erythroid-stimulating agents in the COMMAND study. The other drug to discuss in lower risk is Enterostat. This is a telomerase inhibitor that targets telomerase. Telomere length is shortened in MDS. And the idea here is almost like the synthetic lethality, further shortening the telomere in the malignant cells, leading to their apoptosis. This had been also tested in patients with myeloproliferative diseases. So this phase 2 now is published in JCO by Dr. Platzbecker and Stinsma that looked at once a month IV Enterostat in lower risk MDS patients that were heavily transfusion dependent. Majority of them had ring sideroblasts, similar to the Leuspaticep study. and showed promising results with almost 40% of the patients becoming transfusion independent. And what's more important, around 1/3 of the patients maintaining this response for around a year. In terms of side effects, we do observe cytopenia on target with neutropenia and thrombocytopenia, usually reversible by the time of the second round, but that's the main toxicity with the treatment. And we see on-target activity with inhibition of the telomerase activity and the TERT expression that does correlate with the transfusion independency and duration of response. And very interestingly, in a very small cohort of patients with the SF3B1, 11 patients, we see a reduction in the allele burden of the SF3B1, suggesting that this drug could have disease-modifying activity. So now Enterostat is in a phase 3 in lower-risk MDS patients after ESA failure. I think what's distinguishing it a little bit from Leuspaticep is that the signal of response was observed even in patients with higher transfusion burden. However, it does have the myelosuppression more than what we observe with Leuspaticep. How about hypomethylating agents, oral hypomethylating agents? This is a study by Dr. Garcia-Manero presented at EHA, looking at oral azacitidine, which, as you well know, approved for AML. This was a little bit different schedule of doing 3 weeks of the oral azacitidine. They put patients on this study that were considered a higher risk of the lower risk group by having a thrombocytopenia. So this, again, was a lower risk group MDS patients, but with thrombocytopenia less than 75. The bottom line, 1/3 of the patients became transfusion independent. However, with that regimen of 3 weeks, unfortunately, there was a high grade of neutropenia, febrile neutropenia, and early death that the study was discontinued in that population. So I think we still have to figure the dosing of the oral hypomethylating agents in lower risk MDS patients. We've published before on our experience with an abbreviated course of the hypomethylating agent, sub-Q or IV, with AZA or decitabine 3-day regimen, showing comparable efficacy to the historical 5 days that's commonly used in the USA. And we just finished a randomized clinical trial looking at 5 days AZA versus 3 days AZA versus 3 days decitabine in the lower risk MDS patients. As I mentioned, I typically use hypomethylating agents in the lower risk only if patients have concomitant thrombocytopenia or neutropenia, or if they have really higher risk features. So moving to the higher risk MDS, I think this remains our algorithm. Allogeneic stem cell transplant is still probably the only curative option for our patients. And in patients with higher risk, we favor moving forward to transplant early on in the disease. Typically, we do start hypomethylating agents among those patients. If there is a donor, we subsequently go to transplant. If there is no donor or patients are not fit for intensive chemotherapy for allogeneic transplant, then we continue hypomethylating agents. And after HMA failure and higher risk is really an area of unmet need, where clinical trials, or if patients were able to proceed to transplant, are probably the best options we can offer those patients. Now, we also, in addition to the Leuspaticep, this year in the United States, we got approval of oral decitabine. So this is what we call, the drug name is Encovi, which has cidaziridine, which is an inhibitor of the CD to the stabilization of the decitabine, and it will not be degraded by the gut CDA. The study originally looked at bioequivalency, where the design looked at having patients receive the first cycle of oral versus decitabine and then cross. This was really an elegant design to look at the bioequivalence. And what it showed, basically, it's almost 100% bioequivalent to the IV decitabine. And the preliminary results, and those were updated later on by Dr. Garcia-Manero as well this year, shows that the efficacy is really very similar to IV decitabine. So oral decitabine now is an option for patients in the USA with a higher risk disease. It's important to notice that oral azacitidine that's approved for AML is different. The pharmacokinetics and dynamics with the oral azacitidine are not equivalent to the subcutaneous azacitidine. So we don't use azacitidine outside clinical trials in MDS, while oral decitabine seems to be similar. There is another oral azacitidine from the same company, Addback, is being in development also in MDS. Now, as you know, hypomethylating agents have been the standard for higher risk MDS, but we are trying to improve that bar. What we expect with hypomethylating agents in higher risk MDS in real life is around 50% overall response, less than 20% complete remissions, and a median survival in real life somewhere between year to year and a half. The original AZA001 study that led to the azacitidine approval for higher risk demonstrated a 24-month or 2-year survival that we have never been able to replicate in real life. So what we expect is somewhere around year and a half, around 50% overall responses and 20% CR. So clearly we need to improve that bar. So there are several promising combination therapies upfront in addition to azacitidine. Magrolimab is a drug that targets CD47. CD47 is a receptor expressed in cells. We call it the don't eat me signal. So it blocks the macrophages eating or evading those cells. And it tends to be overexpressed in patients with MDS and AML. Dr. Davar, I think, alluded to this in his presentation as well. So the idea as we block CD47 will allow the macrophages as checkpoint inhibitor, almost immune checkpoint inhibitor, to engulf the leukemia cells. So we've been conducting a phase 1, phase 2 study that we've led in the country, looking at magrolimab azacitidine that included both MDS AML. As you can see, those are highly risk group of patients, majority having poor risk cytogenetics, enriched by therapy-related MDS, very high risk revised IPSS, and subset of those patients, particularly the AML group, having p53 mutation. And so far, we've seen promising results with overall responses approaching around 90%, and the complete response rate more than 50%, and interestingly, around 1/3 of the patients achieving complete cytogenetic response, and a subset of patients also becoming MRD negative with this treatment. What's important also that it seems that the magrolimab is agonistic of somatic mutations, that we see good results in patients with p53 mutation, and this is true both in MDS and AML. This was updated again this year with a larger cohort in the AML than what I'm showing here, but showing same results, high response rates even in patients with p53, and looking more durable than the historical data with p53. In terms of side effects, treatment is very well tolerated in general. There is on-target hemolysis with the first dosing. CD47 is expressed on the red blood cells. So as we treat patients with the first round, we do see on-target hemolysis that subsequently will subside. But if the patients had interruption in their treatment, then we'll have to re-escalate the dosing because this hemolytic anemia will be observed. Other than that, treatment is really well tolerated. This is moving forward in a phase 3 trial currently ongoing, and it's also moving in a phase 3 trial in AML for patients with p53, where there is a randomization between AZA venetoclax versus AZA magrolimab in that p53 mutant AML population. So again, p53 mutant MDS or AML, as you know, is the Achilles heel or Achilles tendon in myeloid diseases with poor outcome. Those patients unfortunately have 4 to 6 month survival. If they proceed to transplant with detectable p53, the median survival or the chances of relapse are more than probably 80% in the first year. So this is really the mother of unmet needs in myeloid diseases. As I showed you, magrolimab is showing promising results. When you look at the data with AZA-VEN in AML, unfortunately, the p53 is probably the group that did not perform well, although the response rates were high. However, the relapse and the survival was poor, with 4 to 5 month overall survival among those patients. So we clearly need more drugs. One of the drugs we've been working at called APR-246. This is a drug that binds p53, and it restores the wild function of the mutant p53. We tested this originally in phase 1 and subsequently in phase 2, and our colleagues also in France were conducting similar study. Both of those studies now are published in JCO. This looked at patients with MDS or AML particularly p53 mutant. Again, you see here very high risk group with complex karyotype as expected, and enriched with therapy-related MDS as well. Again, we observed high response rates, complete responses more than 50%. And when we look at the survival, again, compared to the historical of 4 to 6 months, we see around 10 months overall survival. And particularly among those patients that cleared the p53 and proceeded to transplant, we see a median survival around 14 months in that group. Treatment is well tolerated. There is some neurological toxicity observed that's usually reversible: perioral numbness, dizziness, imbalance. Was more reported with the French group, but mostly reversible. No excessive myelosuppression. So this is finished a phase 3 trial that unfortunately the press release at the preliminary look at the data did not confirm the higher responses with the combination, but we are looking further at the data to try to understand if there is a subset of patients that drove survival benefit from this treatment. Prevendostat is another drug we are looking at. This is an adylation inhibitor that was tested years ago in AML, showing some activity, and now have finished a phase 2 trial and undergoing a phase 3 trial in MDS. This is the phase 2 trial presented by Dr. Addback at ASCO, EHA, and most recently by Dr. Sekeres at ASH, where they took patients with higher risk MDS, oligoblastic AML, and higher risk CMML, randomized them between Prevendostat, AZA versus AZA. And the study primary endpoint was event-free survival in terms of death and AML transformation. Secondary endpoint was overall survival. And the study included, as I mentioned, a group of CMML patients, lower risk or low blastic AML, as well as high risk MDS. When we focus at the patients with higher risk MDS, the study met the primary endpoint of better event-free survival, as shown here, as well as a trend for improved overall survival. There was no clear benefit in patients with CMML particularly, so the study is moving into a phase 3, focusing on with higher risk MDS. In terms of tolerability, the treatment is tolerated, again, very well tolerated. No additive toxicity almost to hypomethylating agents, which makes it as an appealing agent to add to triplet combinations in the future. And here I'm showing the response rates, again, doubling of the CR rates compared to the azacitidine as well. Just briefly covering Venetoclax, because I'm sure you heard a lot about this in AML. In MDS, this is data presented by Dr. Wee. There is an ongoing randomized trial with overall survival goal in MDS. First, the dosing of Venetoclax in MDS is only 14 days, contrary to the AML. In the upfront setting, it shows promising results with overall CR, CRH, probably approaching 60%. The slide is not showing here. The main thing, if obviously like in AML, is the myelosuppression, needing to reevaluate bone marrow after the first round, and those adjusting the Venetoclax in the subsequent cycles. So we are awaiting the final results of the phase 3 in MDS patients, but as I mentioned, the scheduling is different in MDS. And Dr. Zidan also explored use of Addback strategy, adding Venetoclax to hypomethylating agents. We also published our experience with this approach, along with our colleagues from Memorial Sloan Kettering. So those are patients had prior exposure to hypomethylating agents or failure. Venetoclax as single agent really has modest activity, if any, but in the Addback strategy, there is around 20 to 30% overall responses seen. I regard this many times as a bridge to transplant in patients that relapse after hypomethylating agents. Our approach had been, if there are no clinical trials and patients are not candidates for intensive chemotherapy, is shifting the hypomethylating agents and adding Venetoclax as an attempt of a bridge to transplant. It actually have some promising survival data compared to the historical 4 to 6 month overall survival in patients after HMA failure. There are several other drugs to discuss, but in respect of the time, and I'm probably already running beyond the time, I'm just going to mention a few things. Sabatolimab is a drug that targets TIM receptor. This is a very exciting target because it targets both the T cells, or engage the T cells, and targets the leukemia stem cells. Phase 1 data in MDS had been presented showing some promising signal and durable responses. So it's moving into phase 2 and phase 3. IDH1, IDH2 inhibitors, as you know, approved for AML, are looked at as single agent after HMA failure. We have studies moving CPX351 that's approved for AML to be used in patients with MDS that have more than 10% blast as an induction strategy prior to transplant compared to hypomethylating agents. And finally, in the lower risk MDS, Roxadustat, that targets the HIF pathway, is a drug that have shown in phase 1, phase 2, 30 to 40% transfusion independency. Roxadustat is approved in some countries for anemia of renal failure, and this is now in phase 3 in lower risk MDS. So I think this is kind of my hope or vision down the road in the higher risk MDS, that the first time we are having some combination therapies with high response rates, that we can start looking at, a concept of total therapy in higher risk MDS. Treatment backbones hopefully will be doublets or triplets. We will be able to achieve CR, and maybe patients that achieve MRD negativity will start looking at value of transplant, value of maintenance. In patients that MRD positive, again, looking at value of transplant. We are already designing studies looking at potential discontinuation of therapy in patients with MRD negativity in the future. So hopefully this is not going to be just a dream and will be reality, at least in clinical trials in the near future. With that, I think I'll stop. This is my email. Again, please feel free to email me anytime with any question. And it's really a pleasure to be part of this meeting. Thank you very much.